Okay, we're going to keep moving and move on to the next segment of the afternoon. I want to again thank our last speakers, and I want to invite our panelists up. And as they're walking up to the podium, I'm just going to take a minute to introduce each of the people that will be joining us today. There you are. Hoping you receive. Okay, so this next session is a panel where we have invited really some of the leaders in academic surgery from around the country with a strong Northeast presence to participate in a discussion around the impact of economics and health economics on academic institutions. This is a fairly august panel, as I'm sure most of you will recognize just from the names, and none of them really need any kind of formal introduction, but I'll tell you who they are. And we've got Dr. Stan Ashley, who's the Chief Medical Officer at Brigham and Women's Hospital, part of Partners Health. We've got Dr. Barbara Bass, who's the Chair of Surgery at Houston Methodist and MITIE for you, Brian. We've got Dr. Keith Lillemoe, who's the Chair of Surgery at Massachusetts General Hospital, also part of Partners. Dr. Stephen Stain, the Chair of Surgery from Albany Medical Center. And Dr. Jennifer Tseng, the Chair of Surgery at BUMC, Boston University Medical Center here in Boston. And I want to thank all of you for agreeing to take time on your Saturday afternoon to talk to us. I have not sent them questions in advance because these are things that I think all of you at this point live with and struggle with daily. So I'm going to start this and hope for this to become very interactive. I've got a series of questions that I'm going to start with, and then we're going to open it up to the audience to ask their questions. So for those of you that have been here for part of the day, you've gotten a sense of what we've been talking about. The morning was spent really explaining SAGES as an organization and how we have opportunities in SAGES and leadership. And then the afternoon has been really a deep dive into health policy, into economics, and into leadership. And so the five of you are the embodiment of all three of those things put together for us. As a poll for the audience, and this is for our panelists, how many of you are at academic medical centers now? Just raise your hands, please. Okay. How many of you are in private practice? Okay, that's great. That's what we wanted to see. How many of you are employed physicians, not necessarily at an academic medical center? A few more, quite a few more. Okay. So that gives you a sense of your audience in terms of who we have here. It's worth noting that not all academic medical centers are the same. There are many different models, many different financial structures, relationships between medical schools and hospitals and faculty practice organizations can be remarkably variable across academic medical centers nationwide. However, one thing they all have in common is that the economics are changing and the roadmap is changing, and as Dr. Marcus pointed out, the future is still largely unknown. There are certain themes that have become very evident. There is increasing reimbursement austerity for the provider activity. There is increasing reimbursement austerity for the hospital entity, if you will, for the physician and the hospital, which is forcing this move towards increasing alignment between hospital systems, insurers, medical schools, and physicians. So let me ask the panel, and I'll ask you each to just briefly answer for these parts. How many of you have either an accountable care organization or an at-risk contract in place at your facilities now? Everybody? No. Steve doesn't, so 4 out of the 5. Okay. So with that in mind, how do you structure faculty recruitment? How do you adjust faculty compensation in light of the increasing tightness of reimbursement dollars available to you for your department? How has that affected you? How has that affected your ability to recruit faculty? Has it? Dr. Lillemoe, start with you.
So I think Stan and I can say Partners has been in the ACO business probably as long as anyone. Yeah. And so we've been dealing with it for as long as I've been here in 2011 and maybe even before that. I think it's fair to say that we don't lay awake at night worrying about it. That's because we have so many other things to worry about related to referral patterns and access, particularly in eastern Massachusetts. So to answer your question related to recruiting and planning, I think we've been cautious for the last several years, just because we realize, as you said, reimbursements aren't going up. Our networks are limited, at least in eastern Massachusetts. And when we do look to add faculty, we usually look to add them when we know there is an opportunity to serve an area that we may be able to either hold on to referrals or gain referrals in order to make ends meet so that they can add substantially to the division or departmental activities. So ACOs per se are just part of the process, but I do think conservative growth is the pattern that we've followed, which is sad because you see so many great people and great opportunities, people finishing our program, and you'd love to be able to add them just because they're the best athlete available. But again, we have to make sure there's opportunities for them to be successful.
I would say that one of the big challenges with the ACOs is that the contract is done at the partners level, and how we do with that is very hard to translate, even down to the department level, but to the individual doc. They don't see whether we do better than the contract or not. We have kind of a formula for distributing the dollars, but it's to the institutions, and I don't think any of our physicians feel that at all currently, and we've been doing this since the beginning.
Yeah, I agree that there is a disconnect between our newly formed ACO that we're participating in Texas, and I can say that this is one place we're living in Texas. We're kind of 5-10 years behind the rest of the country relative to all of the changes in healthcare finance, and we're also a boomtown kind of environment. We're still growing rapidly. We still have growing population. We still have expanding needs. So again, sort of the heterogeneity of the experience that we have relative to our healthcare systems and the finance around it is probably very, very different in Texas and several other, certainly than California and Massachusetts, that's for sure. I do think that we very carefully scrutinize our investments, and a faculty member is an investment for our organization. We are a unified, unlike some places, we're a unified integrated academic medical center. Within our structure, we have our hospital financial structure, we have our physician organization faculty plan, we have our research institute, we have all of our, we have our educational programs, all kind of sharing ultimately the same bottom line, as opposed to having a separate organization. And therefore, we have a very highly structured recruitment process that specifically is aimed to the various missions that we have within our organization.
Is the medical school on the same balance sheet?
The medical school is at arm's length. We have several medical school relationships. One is Cornell, which of course is way off the radar in terms of the bottom line. But the other is our new A&M medical school. So we now have a new medical school that is part of our system, where we are the primary keepers of those students. It's an NMed, engineering medical school. But they're going to have a separate bottom line, although there's a lot of funds flow back and forth.
So I'm a little different than my august panel members here for a number of reasons, but one of them I will say is that being at a safety net hospital in Massachusetts is an incredibly different thing. We are, I'm behind Dr. Bass in every possible way, but I will say that Massachusetts and Boston Medical Center in particular is ahead of the curve in terms of dealing with ACOs and what predated ACOs. We're now founding a, BACO, which is a Boston accountable care organization, which is going to cover a lot of people in Boston and people in Massachusetts in places. And we are actually trying to figure out how to make it work with a Medicaid book of business, right? So, but because Massachusetts is a place that has traditionally believed in healthcare and has been ahead of the curve in terms of many things, good and bad, in healthcare, and has realized, since the founding of Boston City Hospital in basically 48 or 1864, depending on the date, that healthcare people need health care. So that the state of Massachusetts and the city of Boston have invested in health care from the very beginning. And so that we have been made whole as a department and as a faculty practice group by the citizens of Massachusetts. So we're able to recruit faculty members at, AAMC median levels and pay them. And we don't, every year we still have debates, and I'm sure my faculty are anxiously awaiting the newest iteration of the faculty compensation plan, but we recruit when there's a need for patient care. It's actually kind of pure. We recruit not based on revenue, but when we actually have patient need, and our doctors are working above the median RVU target, then we actually recruit doctors, and we recruit them at 50th percentile AAMC.
That's kind of very similar to what Keith was mentioning, is that you have to have the volume to justify the recruitment. So in the traditional academic medical center model that many of us grew up with, you got hired to build a program, you got hired because you were talented, you got hired because there was promise. That mode is harder to sustain now. Steve, any other thoughts from your end? Since you don't have that ACO structure?
We don't have any ACO, but we're still recruiting, but they're in very specific niches after a approved business plan. I'll give you an example. I need a stone urologist, or I need a prostate urologist. The other area we've been growing quite a bit is working with community surgeons in community hospitals and having them join us. And that's been actually quite a bit of growth, with the belief, unproven yet, that the complex stuff will come to us and the less complex stuff will stay at the community hospitals.
So that brings up, actually, it's a good segue to my next question, which is that many academic medical centers and large hospital systems have been growing through acquisition of physician practices. So whether it's a primary care practice or a surgical practice, those practices are getting subsumed. And as you saw from our audience, we've got representation from all of those different sectors. How have you handled integrating those practices? What are the things that you think about in bringing those practices in? What are some of the challenges you faced in doing so to your organizations?
I'll go first. So, we start by letting them know that they're not going to make any less money. I think that's the worry. They're going to come be university employees and make less money. You start with that. And and I think I learned from Stan, talking to Stan, is that because our hospitals are always full, it has some advantage to us to keep the less sick patients at the community hospitals to make room for more complex cases, which took a while for us to understand. But I think that there's a lot of uncertainty, and even people who don't bring anything to our hospital, we still employ them, keep them in the community hospital, and because we have better contracts, and lower overhead in some cases, we've been able to pay them at least as much money.
Boston Medical Center hasn't really done that. We have clinics and neighborhood health plans, but we don't have satellite hospitals with employed surgeons that we're bringing in. So I'll take a pass on that question.
Well, we've done a fair amount of this in Texas, actually. And part of it is that we are building a network. As many when I got to Texas 12 years ago, we were one hospital in the medical center. We are now a 9-hospital system. But unlike others that have acquired hospitals, we're actually built each and every one of those out of the ground in the last 9 years. And they're now 300 to 400 bed hospitals that are full virtually all the time. So again, it kind of reflects the differences in the market and across our country, and being one of these states that's rapidly growing. That said, we look when we bring a practice on board, and most of our recruits have actually been new recruits. We actually have room for our graduates at these places, which is really nice. But if we bring on a practice, we do a lot of scrutiny of that practice before bringing it on in terms of their expenses, their productivity, their referral patterns. What are they going to give up when they come into our system? Because usually they'll in some ways restrict their referral practices. But what we find almost always, it's sort of sad, but always we see a decline in productivity when they come in our system. And we also see an elevation of expenses, because actually running an expense, many of these practices run really lean. I mean, they are incredibly lean in the infrastructure in which they operate, which is terrific. But if you layer onto that all the compliance and all of the insurance, the self-insurance, and all the stuff that we bring to these practices, the business case for bringing on those practices is not on the pro side. It's on capturing the market to fill up your hospitals with the work that those surgeons do. They all require, I mean, and I refuse to call these subsidies. I call them investments when our hospital helps us with these recruitments. But there's no way that we can bring in those busy private physicians and expect them to remain whole without some ongoing investment in our layered, compliance-rich system.
Yeah, obviously Partners has done a lot of acquiring over the last 15 years in Boston, but I will tell you that from the New York perspective, I'm surprised. In New York City, it's impossible to bring in a practice without adding cost. The compliance issue alone, then adding in the EMR, adding in a lot of the other factors, many of these practices do run incredibly lean. So we're invariably adding cost to the infrastructure of the practice and hoping that we will recoup that cost by more efficiently categorizing the care that's provided. To your point, Steve, lower level care at community hospitals, higher acuity care at the main hospital, utilizing ambulatory surgery sites more effectively, and expanding the referral network. So it's been challenging for us.
But it's also very clear that there's where you can only do that if you're working with your institution leadership. I mean, this is a team sport in terms of bringing these practices on board, because you may end up looking on the negative side, on the pro-fee side, but in fact, we always have to keep that obvious value to the institution in mind.
Keith, Stan, any thoughts?
So Steve mentioned this pathway. We've had a long relationship with a community hospital that's about 15 minutes from us. Have had problems with our occupancy being in the high 90s for years, and care really is cheaper at those places. So we have increasingly tried to move all our secondary and more of our tertiary care to this community hospital. Their docs are now fully integrated with our physician organization, and it really has worked. Many of the payers tier that institution better than the Brigham, so a patient has a lower copay if their surgery is done there. A surgeon that works primarily at the community hospital has a better tier than somebody who works primarily at the Brigham. So it really has, for an awful lot of general surgery, for orthopedics, it's probably a better thing for them to be doing those cases at the community hospital. It's a hard thing because many of our docs will operate at two different places. There'll be one place one day and another. Getting those cultures so it doesn't feel like you're working at a very different institution, et cetera, has taken a long time, but I think it is really working now.
So I guess not having Torch here, we can maybe speak a little less muzzled than perhaps. Partners and our individual hospitals have made acquisitions, but have not really acquired a lot of physician groups in the surgical specialties yet. And that's with really one exception, and that was a long-time relationship with the hospital up at Salem and a private group that we brought in. I do think it is necessary that you have to have the groups working together, because if not, they are still viewed as your competition, and if you can't share the physician bottom line, it makes it hard then to go to Big Brother, i.e. the hospital or health system, to justify those added expenses. We are doing a different model with another hospital where we're helping to basically hire individuals to our department that will be based there rather than acquiring a group of physicians. Although I know some of the other specialties, such as orthopedics and urology, are in the midst of those kind of efforts. The hospital acquisition is, it's different. You know, most of the doctors at those hospitals do not work for the hospital. They are independent. And so just because you have a relationship with a hospital in New Hampshire or even in Massachusetts there is no guarantee that you will become that tertiary referral site. You have to make that work based on the same criteria that we've always had to build practices, which is affability, availability, and specialty, ability, but specialty ability, because we're not there to, as everyone has alluded to, we're not there to take the cases that they should be doing in that institution. We're there to take over the care of the patients that they can't handle at that institution, and making sure that that's easy and seamless for them without economic loss, I think, is important.
One of the hardest challenges of that is getting that institution to believe that they can't handle those cases. So where they've been doing, and I know regionalization has come to the Northeast very aggressively, a hospital that does 2 pancreatic duodenectomies a year thinks they can do it just fine. They don't have a mortality, and now you come along as the academic center and say, no, you can't do those 2 Whipples a year anymore, even though you haven't had a death in 10 years in doing 20 that you did. So that culture change can be very difficult to create, where you're saying, okay, we're regionalizing care internally within our system and convincing not just the hospitals, which you may be acquiring, but then the providers within those hospitals, that one surgeon who was doing the 2 Whipples a year, you're telling them, no, you can't do those anymore.
So Stan and I and our hospital leadership and our departmental leadership did not take the U.S. News volume outcome quality pledge that some of the other institutions did, mainly because we didn't feel we wanted to be part of restricting, creating that limitation. We've gone about it the other way. For example, one of our best liver surgeons has gone out to the community and helped some of the people do operations out there so that they can stay in the community as opposed to coming down. And again, I think making sure that there are Whipple procedures, and then there are Whipple procedures that are extraordinarily more difficult for whatever reason. It might be adjuvant therapy, locally advanced, et cetera. And although I certainly have drank the volume outcome Kool-Aid for decades, when you're taking somebody's livelihood away from them, and particularly in a hospital where they have your residents taking care of the patients, it's a little bit more of a tougher thing to do. So we've held off on setting limits of what they can do. On the other hand, if they're your partners and have an employed relationship, perhaps the benefit of not having to take care of those patients and worry about those patients will be easier for them to swallow than if we were truly in competition.
Steve, has that been your experience too?
Well, in our area, nobody wants to do Whipples, esophaguses. We've had a little issue on rectal cancer. We've seen the community hospital continue to do rectal resections, and with some positive margins, some early recurrences. So we're actually starting to collect data with our primary insurance company about ostrich criteria, or whether they're following whether we're following them and whether they're following them. And we think rectal cancer probably is a disease where we're going to get our employed doctors to send their patients back to us for rectal cancer, because we've seen a lot of positive margin early recurrence.
So I want to encourage you to step up to the microphones with any questions that you have, and while people are doing that, I've got a couple more, but feel free to come up because I do want to make this interactive. So one of the questions that's come up throughout the day today, and Ray Price actually raised the example from Intermountain, as institutions are creating programs to shift to value-based care and recognizing that we've got to do this shift to value, which is obviously quality over cost, and the practical translation of that at most hospital systems is reduce cost. So it gets pushed onto the providers, it gets pushed onto the surgeons, achieve cost reduction, and there are some very effective methods to do that where you can engage surgeons to do it. But how do you address, or how are you addressing, I should say, at your institutions, the engagement of the surgeon in that? Do you have gain sharing? Do you offer gain sharing to your surgeons for the cost reductions achieved, for the quality improvements achieved, or both?
There's
Just a little bit about some of the quality incentives that we use for our faculty and in our organization at large. We are focusing primarily, we have most of our surgeons at the higher level, senior surgeons, all of our executive leadership team, all of our chairs have an at-risk clause in our annual compensation. And it ranges from 10 to 20%. Of that at-risk margin, about 30% of it is related to operational efficiency. About 30% is related to quality, i.e., not qualities that we are necessarily content with, but measurable qualities based on our Vizient data, such as mortality, PSI, core measures, whatever it happens to be. About 30% of our bonus comp is at risk for that. And even things as simple as our patient satisfaction scores. That's actually built into our contracts on an annual basis. We are a place that has highly structured contracts for our employment. So I think it's interesting, and it applies from our CEO, president, all the way down to the senior physician group. For our more junior faculty and our new contracts for those, we have incorporated some element that reflects the quality mission. In terms of cost, and we get that money just from our operational funds on an annual basis. We do have a couple of at-risk contracts now, and that has been held primarily at the hospital level. That hasn't been trickled down to the provider level. Things like the never events of retained objects and things like that. But we do not. I think the place where we're going to get closest to that first is where in Texas we are likely to see our first sets of bundled payments. Right now we are still not there. We're still not talking a lot about value-based care in Texas, but we're talking about it, but not worrying about it too much. And that'll be in orthopedics and in coronary interventions. Yeah.
It's a fascinating thing, having been at a bunch of different institutions in the same geographic location, having gone from UMass, which is also a safety net hospital and an academic hospital, to BIDMC, which is wonderful and super sort of private insurance-driven hospital, and now at Boston Medical Center. It is very interesting to see hospitals get tiered out of care because they're, and I was at Mass General, of course, I didn't forget that for 10 years, but to tiered out of care. So I would have patients that could not see my great partners at UMass, and because BIDMC was a little bit perceived as good outcomes and lower cost, they could not go to partners, they could not see Christina Froni, they could not see Giles Whalen, they had to come see me. Boston Medical Center actually now, knock on wood, has levels in the 10th highest decile, right? In the 10th decile. We went from the lowest to the top, and nothing to do with me, my predecessors. And so we actually, everybody can come to us. So we have a whole bunch of patients that come to us from Boston Children's Hospital because they can't go there, so that they can come and have their circ at Boston Medical Center, because we are perceived in the, Boston's a weird place, Massachusetts is a weird place, the Attorney General's on people in Boston Globe and everything else, but we are seeing a lot of business because we are perceived as very high value, low cost, and our surgeons have all drunk that Kool-Aid, so that we participate, and if we repurpose ligature, right? If we repurpose, and we all agree, and so we try to make it as transparent as possible. Okay, all the surgeons are going to try it, and if they don't like it, we're not going to use the repurposed ligatures. But if they're the same, they actually see what the cost savings are, not necessarily in their paycheck, but actually in terms of the bottom line.
That's the question. Do any of your institutions have a method to gain share the cost savings with either the department level or the surgeon level?
So I would say that since we have no real hospital-defined fund flow mechanism, we have no gain sharing whatsoever in our department, and therefore we have not translated that into physician or surgeon comp, other than some minor little trivial incentives that our physicians organization put in. There has been one exception to that that's been done as an experimental model for our heart center, our cardiac surgeons, and literally those data just came from the end of fiscal year 17, which wrapped up on September 30th, and I haven't had an opportunity to completely digest that, but from what I've learned, our surgeons did pretty well with that, so I am going to try to understand that a little bit better to see if we can more broadly apply that, because up till now, although we measure, report, and share these outcomes and emphasize quality, as well as cutting costs in the OR in terms of equipment and particularly in the high-end specialties like orthopedics with a lot of prostheses and equipment and catheters and devices. That has essentially helped keep the hospital margin good. It has not translated into us.
Because the physician organization and the faculty practice are completely separate balance sheet.
They're not, they are separate. There's certainly a lot of interaction back and forth, and I'm not going to complain that there's no hospital support, but we do not have a set financial fund flow model where monies come to us either by volume activity or by quality activities.
So there are questions on the floor. I'll just add, so from my perspective, at my institution at NYU, we actually started a program for this. New York State had something called the Greater New York Hospital Association, which actually did have a very small gain-sharing program for individual physicians, individual surgeons in particular, around things like implant use. And we left that 2 years ago, and we've just developed a new value-based incentive program that's targeted at the department level, not at the individual provider, but as a department head, I can see what each individual physician in the department has contributed to, either on the plus side or the negative side, and then we have a really arcane calculation that the finance guys came up with where we get to essentially get 25% of everything that we save back to the department as a lump sum quarterly payment, and we get a quality modifier on that. Unfortunately, the quality metrics are not metrics that surgeons would choose because they're very generic Vizient-based quality metrics, and we're hopefully changing that. But we're on the bleeding edge of trying to figure out how to do that. So with that, Dimitri.
I'm astonished that you believe the numbers.
Actually, so that the one thing I can say is because our institution is, like yours, a totally integrated medical center, including the medical school. We do have a single central data warehouse. All the financial, clinical, and management data all consolidate, including supply chain. And so the numbers are actually real. Utilization data is accurate. It's not claims-based. It's actually use-based. So we can trust the numbers. We had to get to that point first, and we dashboard everything. So I've got a dashboard. I got more dashboards than you can imagine, but it's there. Dimitri.
Dmitry Olenikov, Omaha, Nebraska. Thank you very much. I think this is an extraordinarily important discussion. I have a question that pertains to the hospital coming to the department, and in this case coming to my division and telling me that we're spending too much money in the operating room because, well, we're minimally invasive surgeons, so that's expensive. We use the robot. Well, that's crazy expensive. And then they benchmark us against open surgery, essentially, and they sort of ignore the total cost of the entire care process, longest stays, complications, and they just look at the supplies. And so I'm always trying to advocate for our group because, you know, to do what we do, we need special equipment. And I'm just wondering what's your experience in this, and what do you think is a good way to sort of show the hospital that the budget really, you know, the OR budget really is not just one silo, but it's part of the hospital's budget, which does look at the entire episode, the cost of the episode of care. Thank you.
I'll take that one a little bit. This is one area where I think if we look forward, especially to the bundled care model, the notion that and Brian Duncan, who works with me, has done a lot of this work in terms of demonstrating the value of minimally invasive surgery relative to overall cost, even if you have a higher upfront technical cost. But I would say that we have many metrics that we follow. One is OR cost, the time of OR cost, the length of stay overall, and if you bundle them all up together, you end up in a win. But it's very essential, obviously, that you have that ability to bundle the expenses or the costs in an understandable way. And I think in most of our institutions we'll go on a binge where, okay, we're going to focus on the OR equipment costs for a little while here, but then we'll come to length of stay, then we'll come to some outcome that we want to particularly focus on. But I think that's our job, is to try to keep the eye on the meaningful bundled outcomes and processes that we can deliver on. The interesting thing I also think is that you know, we have in our hospital, it's very tough for us to get believable numbers relative to our actual expenses in the OR, whether it's time or equipment or whatever it happens to be. So we have not really focused on that. I will say, however, for the most part, you know, the places that get a lot of attention are the two departments that are not in my department, which is orthopedics and neurosurgery, which are high volume, high expense. And so we always look pretty good because we actually, you know, we don't do a lot of that fancy, expensive stuff. And we do get people out of the hospital quickly. We do measure and track our outcomes and our quality. So I think sometimes the best strategy there is to kind of deflect the attention elsewhere, where they might actually have some real opportunity to recoup some genuine big dollars.
I think there needs to be some compromise, though. So at least if you are perceived at your institution as somebody who you're actually going to listen, you're not going to be wed to your hypothesis. Yes, I need to do this with 2 robots. I cannot do it laparoscopically. I cannot. In no situation will I ever do it open, even if it's open's going to take me 2 hours, and if I'm going to do it with a robot, it's going to take me 8 hours for some reason. I'm not saying that's for you. I'm just saying, like, for me or for something. So, but you have to at least be willing to listen and then come back with data and say, well, actually, our service does. I don't know what your practice is, but you know, I do my, you know, so I use minimally invasive, and I can do 6 minimally invasive. I do them very quickly, and the upfront cost is higher, but they leave the hospital sooner, and et cetera. You have to have the data, and I don't know. Len Marcus was. I saw he was here in a previous session that I have been at that he's taught. He went all about how you basically do this listen and the BATNA and like what is the getting to yes, right? You're not going to be wed to your hypothesis. You're going to listen to the other person and figure out what they want to do, and then come back and get what you want instead of like haggling over a rug.
Any other thoughts?
Just quickly, so we don't necessarily believe the data that our finance people show us either, but when we just showed the surgeon the actual cost of a piece of mesh, just that simple cost, and one person used a type of mesh for their Nissens repairing the high edge, which was $400 more, and he changed that day. So I think it's relatively simple information about costs of specific things surgeons do respond to.
Unless they're
Lena.
Right.
Lena Caton from Cleveland, Ohio. I really appreciate this panel, and this is a really important discussion, particularly at our place. We've kind of gone to an RVU-based payment to all of the physicians, and yet we're at an academic medical center, and everybody's there who is there is passionate about academics. And I just love to hear how you have, you know, in the current healthcare economics, you know, how you value academic productivity within your departments, and how does that factor into the equation?
So, as they say, there's only 2 times that you can change a compensation plan. One is when you're coming in and one when you're going out. And so I was given that responsibility when I came in, now pushing on to 7 years. So we're 4 years into a comp plan, which is RVU driven. We have been able to build in some academic incentives, but I would just say, despite the fact I do believe that we have a highly motivated academic group, when we've approached the faculty, and this is through our faculty advisory committee, which is elected representatives from each of the divisions, and we've asked them, would you like to lower the dollars per RVU to provide academic incentives? They have pushed back on that. And again, I don't know what type of leader I am, but generally I'm sort of follow what I'm told by what they want. And so even though in my heart of hearts I would have loved to have done that, when it was so overwhelmingly against that, I've left well enough alone. So.
We started probably about 10 years ago with a 1% withhold that was redistributed based on academic metrics. It's now up to 5%. The metrics are decided by each of the divisions, and I think it probably will continue to grow. I think most people feel like it's the right thing to do.
I think I've been amazed by, even at what we would think of some of the most prestigious academic institutions in the country, it's still based on clinical productivity. And so in our place, by division, some of the best paid divisions, plastic surgery, at least has talked about withholding pooled money to use for those purposes or to bring up the lower producers. But I think it's not true that most places have money that's taken out just for academic. You have to pay the productive people to keep them productive.
I think, I've only been chair since July, right? And so I think this is a little bit differently now because there's actually a fixed sum of money that you have to do all the things that you're supposed to do. And the biggest thing is payroll. The biggest thing is paying your faculty. So then at the end, there isn't, God will provide, there isn't like an extra sum of money to use. So how are you going to pay people? Are you going to tell people that the guy or the woman who brings in all that dough is going to give half of their dough to person X who is doing grants and papers, and I've been on the grants and paper side, but it has to be, everybody has to buy into that proposition. So at our institution, my predecessor Jerry Dougherty put in a plan which was extremely generous because times were actually more flush, but where people would be paid at 50% double AMC, and then when they got promoted, they would be bumped all the way up to that associate professor 50% median double AMC. Now that is actually extremely generous because that's all associate professors, not beginning associate professors, and never mind we're at a safety net hospital. So we're reevaluating the comp plan, as you can imagine, which is also not a popular plan for those people that are about to be promoted to associate professor, but we do have that. That's where we get the academic bump, is when they actually get promoted. And they start at assistant, they don't start at instructor, they start at assistant. So they get a pretty substantial bump at associate and at full professor.
I think having sat at the Society of Surgical Chairs and heard Mike Mulholland present their comp plan, where essentially they went straight salary across the board with very little clinical incentive. It can be done, and obviously the Mayo Clinic has done that for years, but having gone from a place which really had a P&L based comp plan to something that was RVU based with some academic incentives, we have to walk before we run. So,
I think I get to agree with Jennifer that really you got to look where that money comes from and what are your opportunities for bringing money into your department. No question that for most surgeons, their largest chunk of time is their clinical activity, and we need to track that. And at this point, the only metric we really have is work RVU, and thankfully we have a work RVU as opposed to a collections kind of model,
right,
which is sort of the
faculty make nothing.
Yeah, so that's sort of the old model. So thankfully we don't have that. But then again, I think we also have to find ways to compensate people for the additional roles they had. Sometimes that's a medical director role in the hospital. Sometimes it's a funded strategy within our education systems, whether it's as an associate program director or program director or something like that, whether it's a special thing like running MITIE, whether it's something that we can bring some additional funds on relative to an endowed position. So I think there are different ways to do that mission-based financing that capture the different roles people have, but you got to follow the money. There's also in our annual budgeting process, which I'm sure virtually all of you go through, there's a line-by-line kind of allocation of any additional funds that come into our hospital to our department from the hospital, and that's my chance to do some of that fine-tuning.
To capture some of it. Question with you.
Julianne Banner, and from the Mayo Clinic, indeed. One of the questions I have, listening to all of the different theories and concerns, and I've seen some of the RVU-based payment saying, okay, that's going to improve satisfaction if you pay more to the people who work the hardest, this, that, and the other. And then shortly thereafter, there were data saying, no, that doesn't actually work. Have you found it effective to use monetary rewards to improve the motivation of the people who work with you on quality, academic productivity, and things like that? Is it, is it actually the most effective method, or is there something else we can use?
Like I say, in my place, we actually have programmatic bonuses for some people. A programmatic bonus can be anything from, okay, you turned in your first NIH grant. You didn't necessarily get funded, but you wrote it. It can be something about publishing or presentations, and we have a dollar figure that goes with that for those faculty that are engaged that way. For quality, we have certain, for people that are actually actively engaged and quality. Those are medical director compensated positions. If we're really going to ask someone to spend a day a week or more than that on quality, we compensate that distinctly. And it is, well, it's a burden and a curse. I mean, when you have these structured contracts that actually capture your expected effort, it's often very helpful to both assess the performance of someone in those roles and say, hey, great job, you're doing great, let's keep going, or to say, well, maybe we ought to change this to let somebody else have a shot at that one.
Sharona?
My name is Sharona Ross. I'm from Florida Hospital, Tampa, and it's interesting I used to be an academic environment, and to go now and work with a hospital system, which was the Adventist. It's interesting how they're managing us. And what do I mean by that is we'll have a conference call with all the different hospitals in the different states, and they'll go over the cost. So you have administrative people and then surgeons all sitting, and we look through the cost of each hospital down to the instruments, trocars, different companies, and where do they get the best price. And then we, as the surgeons, we get to kind of talk to the different surgeons from the other hospital and talk about the benefits and advantages, disadvantages of the instrument itself. My question is, so in other words, they brought it to us to make us part of the solution in choosing which instrument, because many of them have the same quality. It's just that's what we used when we were training, not necessarily because we must use this instrument. And so my question to you is, what do you think about standardization of operations and therefore developing toolboxes where we determine the qualities of many of the main companies are very similar, where we determine what toolboxes we're going to need for each operation. If it's robotic, what instruments, because otherwise we spend a lot of money on the different instruments which we not necessarily need. Vessel sealer versus the hook. I mean, you make them, some people prefer the scissors versus the hook, but they're all the same thing. So do you need to open all of them or just a few of them? That's a decision that we can make for, to the administrative people, and then come up with a toolbox that lead for the best instruments, but not necessarily the most costly instruments, but something that we can use for all of our minimally invasive operations. And same for single incision laparoscopy and, of course, conventional laparoscopy.
So standardization across the department. Are you doing that?
Trying. Everybody's trying to do this, right? So this is the whole service line thing, the pancreas, various things. It's hard, right? So my new place of CPD is a big issue. So they'll open, when Jason Hall, our chief of colorectal surgery, needs whatever the colorectal instrument, I'm glad I never have to look at again, but he's very good at it, they have to open a whole new kit, right? And so there's all these kits, and then they wonder whether there isn't a kit for the next case. So sanitizing of everything, not just the expensive laparoscopic equipment, but that'll save time and money.
So I heard an amazing presentation a couple weeks ago. Stan was in the room. That if we could save $5 a day on a case, $5 in a case, it would save the system, $5 or $6 million.
Well, we can do that.
Yeah, we can just by not opening one proline. Right. I mean, and look I'm a maximally invasive surgeon, not a minimally invasive surgeon. So most of what I do are soaks and Vicryl, not much more than that. But the bottom line is we do have to change the culture that, having more is better. I mean, having everything open, just because I might want to have both the harmonic scalpel and the ligature. So those are things that we're trying to do. But at least as of now, we are not financially incentivized as surgeons to do that. We're doing it for the team concept, recognizing that if the hospital saves millions of dollars, then we may have better access to other support mechanisms.
Well, excellent job moderating. I've gotten a lot of tweets and feedback over the last couple of weeks with a simple question, well, just people in awe that we have this panel. And they said, you got the best role models coming in. We got the highest leaders from the American College of Surgeons, SSAT, ACS. How did you do it? And I said, I just asked. And I think it speaks to all of you, and we very much thankful for your time today and coming here from Texas and driving out from New York. And I know we have a lot of junior people here that if you're still here at the network would like to kind of build up the courage to come say hi to you. So I encourage our younger guys to do that. But thank you very much.